Welcome to our third annual Hopkins Center for Health Disparity Solutions Symposium. I want to just greet you all and thank you all for taking time out of your busy schedules to come and have an important conversation that we will engage in for the next few or 4 hours. My name is Daryl Gaskin. I am the director of the Center for Health Disparity Solutions. And I just have the pleasure of really, in a real sense, being the a figurehead or front man for a wonderful and very talented group of researchers and community leaders and staff members who do excellent work in the field of health disparities and health equity. I would ask that you take some time during this symposium to tweet about us and talk about what we're doing. We have a hashtag that you can use. It's hashtag annual symposium. And so we would hope that you would engage in conversation online as we delve with this very important symposium and this very important conversation. First, I want to, we'll give, next slide, Chantel. First, I'd like to give some remarks, and then I'm going to ask our program officer, Dr. Deborah Linares, as she would give some opening remarks before we have comments from our very special guest, our keynote speaker, who I'll introduce shortly. But first, let me give some opening remarks. Next slide. So the theme of our program today is race and racism in our research training and public health practice. And so I thought, as to sort of set the tone, I would take us back to one of, I think, sort of like the founding or most profound statements about racial and health disparities, which were given by Dr. King. Next slide. And so many of us know this quote that Dr. King is attributed to Dr. King, that of all forms of inequality and injustice in healthcare is the most shocking and humane. And in a real sense, health disparities, health inequities is a real social justice issue. It's a fundamental issue of social justice. Next slide. So, next slide. Yeah, so many of us are familiar with the 1963 March on Washington. It was organized by the Big Six, John Lewis, who we just recently lost, Whitney Young, Philip Randolph, and Dr. King, Dr. Farmer, and Roy Wilkins. And many of us are familiar with this march, and we're familiar with it every year during the King holiday, as well as during Black History Month, and then on the anniversary of Dr. King's assassination, we hear about this march. Next slide. Now, this march was very well choreographed. And if you go to the Civil Rights Museum in Atlanta, you actually can hear certainly a lot more details about this particular speech. I like to say that there were 10 speakers, but there were 11 speeches. 10 speakers, but 11 speeches. And what do I mean by that? I mean, the planners and organizers of this event had each of the speakers write their speeches out, and they vetted them. And there's some discussion about some language which was in the speech that was given by John Lewis, which was edited out. And so it was very well choreographed. And so there are 10 speeches which were written. And I would ask that if any of you know the text of any of those 10 speeches, you are a historian, you're not in the general public. But there is an 11th speech that wasn't written, and that is the speech that you know very well. Next slide. So the order of the speeches was really given, was determined the night before. And actually, Dr. King was not at that meeting. And it was Dorothy Height that recommended that Dr. King be the last speaker. And so he ends up being the last speaker, and he has a written speech which was prepared for that moment. But it's in that speech that we also then get what I call the 11th speech. And that 11th speech is the one that you and I remember very well. And so it's Dorothy Height and Mahalia Jackson make sure in a real sense that we get the 11th speech. Let's go on to the next slide. So when Dr. King is finishing up his prepared remarks, Mahalia Jackson says to him, she says, "Tell him about the dream, Martin. Tell him about the dream." And then Dr. King then goes on to give the famous "I Have a Dream" speech. And this is a speech that he has given before in some other settings. And so he gives a variation of that speech, and that's the speech that we all know. And I find it quite enlightening, really, that of all the speeches that were given that day, all of them that was written and vetted and so forth, the one speech that really was not vetted is the speech that all of us remember. So I think that's divine intervention there in a real sense. Next slide. And so I like to think that this 11th speech is really God speaking to the nation. And it's his expressing his desires to the nation through this Baptist preacher who we know as the Reverend Dr. Martin Luther King. And he says in this speech, "I have a dream that one day that this nation will rise up and live out the true meaning of its creed." And so in a real sense, it's a call to us to live out the meaning of the creed of America. What's the creed of America? Next slide. The creed of America is quite simple. It says, "We hold these truths to be self-evident, that all men are created equal and that they are endowed by their creators with an uncertain, unalienable rights, that among them these are life, liberty, and the pursuit of happiness." And it's this thing that sort of makes us all Americans, that we adhere to this creed. And so when Dr. King, he's a good Baptist preacher, he's going to tell us what it is that we need to do in order to get to this creed. Next slide. So Dr. King actually tells us that he has a dream, and that dream means that we have to pursue diversity, we have to pursue equity, and we have to pursue inclusion. And he doesn't use those words that we use today, but when you analyze the dream and you look at the speech, you realize that that's what he's talking about: diversity, equity, and inclusion. Next slide. So he says, in his dream, he says, "I have a dream that my 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character." And this is this plea that we will select the folks who we include in whatever it is that we're doing based upon merit, based upon the content of their character, not based upon their race or their creed, their religion, or what tribe they're from, but really based upon what they are going to be able to contribute to what it is that we're actually doing. This is a plea for diversity. Next slide. Next slide. He says, I have a dream that one day every valley and every will be exalted, every hill and mountain made low, the rough places made plain, the crooked places made straight, and the glory of the Lord will be revealed, and all flesh shall see it together. This is our hope. And he says this is a plea for equity. And in a real sense, equity in the sense that when we think about health equity, how people are able to achieve their highest sense of health and wellness, so that no one is made above someone else and no one is thought of as being low, but that in a real sense that we seek and strive for a place where equity is our value. Next slide, please. And then this last point, so we went diversity, we went equity, but then we also want inclusion. And he says, when he ends that speech, which when all God's children will be able to sing with new meaning, my country 'tis of thee, sweet land of liberty, of thee I sing, let freedom ring. And I ask the question, freedom from what? Freedom from what? What is it we need freedom from? Freedom from racism, freedom from bigotry, freedom from those values that for a long time had separated Americans, have determined who can do what and who can be where, who can live where. And in a real sense, racism and bigotry sort of robs us of our best selves. I sort of say in the persons who promote bigotry, insisting that only one group can do this thing, as opposed to allowing all of us to be able to participate to the best of our ability, is like a musician that only plays in the key of C. Because the key of C is one of those things where you can only use the white keys and when you're playing in the key of C, except every once in a while you have an accidental and you might use one of the black keys. But in a real sense, if we want to free up the musician so that he can play in all the keys and whatever key he wants to play in. And this is freedom, freedom ring from racism, freedom ring from bigotry. So as you're thinking about these issues, and that I have a dream speech, it is really a speech that God calling this nation to think about and to live up to its creed by pursuing diversity, by pursuing equity, and by pursuing inclusion. Next slide, please. So as we think about these issues in this particular symposium, I would certainly encourage you all and reflect on that speech to remember when you're thinking about it, it's just not the oratory skills of Dr. King, but it's really in a real sense, God speaking to a nation. And this is in a real sense, our season to try to bring some of these values to bear. So now it's my pleasure, since I've given my opening remarks, I want to now turn the program over to Dr. Deborah Linares. And Dr. Linares is our program officer at the NIMHD. She is a health science administrator. She focuses on promoting health, on promoting research to understand behavioral and interpersonal factors contributing to the resiliency and susceptibility of adverse health conditions among disadvantaged and underserved populations. She provides expertise in conducting minority health and health disparity research in the area of behavioral health, women's health, child development, healthy aging, and e-health and cancer control. Before joining NIMHD, Dr. Linares worked as a health science and program officer at the Health Resources and Services Administration in Maternal and Child Health Bureau. She holds a doctorate degree Doctor in Philosophy degree in Community Health from the University of Illinois, Urbana-Champaign, where she studied behavioral health, survey, measurement development, and program evaluation. So I'm going to ask Dr. Linares if you would kindly give us some opening remarks for our symposium.
Sure. Thank you so much, Dr. Gaskin, for a wonderful introduction. And thank you for the inspiring words about Dr. Martin Luther King. And whoa, my face is very large on the screen. I'm not quite used to that. So, you know, I think it was quite very well said, and you really make a tough act to follow. But I'm going to keep it short because I know we have some excellent speakers lined up today who have some very important issues to discuss. But I just wanted to reiterate what Dr. Gaskin mentioned in terms of racism being a critical issue in terms of driving health disparities, perpetuating health disparities, you know, and something that we really need to focus on in our work here. In particular, to create health equity, to create opportunities for everyone here. And so the National Institute of Minority Health and Health Disparities really sees this as a critical component in terms of addressing health disparities. And we have some efforts currently underway in terms of that. So I would encourage you to keep a lookout for those. But also I want to thank the team, Dr. Gaskin and his team, and everyone that has put a lot of work into this symposium for today. I think it's going to be an excellent symposium. And I want to, in particular, give a thank you to the Hopkins Center for Health Disparity Solutions, everyone on the team, and also in the community that plays a critical role in putting this symposium together. And I also want to thank Dr. Keith Norris for presenting for us today. I'm really looking forward to your presentation, and I know that we all are going to learn so much. So thank you so much as well, Dr. Gaskin, and I'm going to turn it over back to you to continue on with this afternoon. Thank you, and I look forward to the next few hours.
Thank you, Dr. Norris, for those very kind comments. And I too am looking forward to our keynote speaker, who is Dr. Keith Norris, who is professor of medicine at the UCLA Division of Internal Medicine and Health Services Research. Dr. Norris is an internationally recognized clinician scientist and health policy leader who has been instrumental in shaping national health policy and clinical practice guidelines in the area of kidney disease. He has been one of the most highly funded NIH investigators in the nation and one of the most highly cited scientists in the world in the area of chronic kidney disease and health disparities. He has been a powerful advocate for minority institutions and served for 7 years as the president of the Research Centers and Minority Institutions Program Association. After leaving Cornell in 1976 at the age of 19, he attended Howard University College of Medicine, where he graduated in 1980 and was inducted in the Alpha Omega Alpha Medical Honor Society. He then completed his residency training and chief residency in internal medicine. And from 1983 to 1986, he trained in nephrology at the combined West Los Angeles Veterans Administration UCLA program. In addition to being board certified in internal medicine and nephrology, he is an American Society of Hypertension specialist in clinical hypertension. And in 2014, he received his doctorate in religion and spiritual and metaphysical philosophy. After serving as the VP of Research and Health Affairs and interim president of the Charles Drew University, he returned to UCLA as a professor of medicine and co-director of the Clinical and Translational Science Institute and Community Engagement Research Program. And I just apologize. I do have a landline that I never answer, but nonetheless, people nonetheless continue to want to call me on it and ask me to give them money. Let me just say this one last thing, and then I will turn it over to Dr. Norris. He is a prolific author and writer. He's co-authored over 450 peer-reviewed journal articles and book chapters, and he served as editor-in-chief and emeritus of the International Journal Ethnicity and Disease. So I would encourage you, why don't you let us give a very warm welcome, and if you know how to give the hand claps in Zoom, you can use your reaction and give a very warm welcome to our guest, Dr. Keith Norris. Thank you so much, sir.
Thank you very much, Dr. Gaskin, and to the audience, thank you so much for inviting me today. I'm ready to just say what he said, and then that's it, and then go to Q&A, and I'll be good. That was just an amazing introduction, Dr. Gaskin. It was very inspiring, and so it's great to be here today, and I also look forward to being able to stay around and participate with the community-led session, because that's like what's really fun for me, stuff like that. So let's get going here so we can go through a few things and go to Q&A so we can pass this. This is just what, what I'll be talking about. And so next slide. I have no conflicts of interest, except I believe in a society grounded in equity and justice. So that is my bias there. Next. So part of the reason why we're here today and talking on this topic is, despite all the efforts that were done in the 1960s and before that, major race-based inequities continue to exist, both in society and in medicine. And that leads to the disparities we see between racial ethnic groups, and it undermines the optimal care for all. I know a lot of people have said, didn't things get better? Didn't all discrimination and racism end with the Civil Rights Bill of 1964? But other people are saying, well, I thought maybe it ended with the Civil Rights Bill of 1866. So that didn't really happen, and it didn't happen in 64 either. So we still need to look into these issues and figure out what we can do until we get to the point where we're realizing the dream of Dr. King. Next. So a few definitions. Next. So I think many people are aware that there's one race, the human race. And this has been articulated many times through the World Health Organization, UNESCO, Pan American Health Organization, and that the term race, that as we use it, is really a misnomer, right? Because there's really technically one race, and then we created all these sort of sub-races that really don't exist. The Pan American Health Organization uses ethnicity to describe and characterize different groups that share tradition, ancestry, language, culture, religion, etc. And that would be great to get to at some point in time. But while we still have racism here in the United States, we still need to recognize that and work through that, because we do have these disparities, and we just don't want to get rid of the terminology, collect data differently, and then we don't recognize that groups are being treated differently. Next. So what is race? From Kamara Jones, social interpretation of how one looks in a race stratified society, right? So it's a social construct, but it's really a social political construct. And it's designed to control power and marginalize people based on how they look, right? And so we have this white supremacy ideology, and that's what causes the consternation in the country right now, right? So we heard America's creed, which is all men are created equal. Yet we have it this white supremacy ideology that says all people are not equal, we have actually created subgroups of individuals, and then there's and those people are inferior. And so it was originally to maintain, to justify and maintain Native American and American Indian genocide and oppression, and Black American chattel slavery and oppression, but it continues today in many different facets. Importantly, as scientists here and people involved in the Center for Health Disparity Solutions, it's also important to understand that race is not directly related to ancestry. It's indirectly related to ancestry, but it's not directly related, okay? Right, so if a recent immigrant from Nigeria comes here, and then there's someone who's a Black American, African American who's been here for multiple years, multiple generations. Look at me, my family comes from a slave plantation in Maryland. And an Australian Aborigine comes here. All three will be labeled Black or African American, but their ancestry is not the same, right? So there is some relationship, but it's not really the same. So in research, race is a very poor indicator of biology and genetics. And what it is, and we'll talk about it, it's a strong indicator of exposure to racism in the United States. Next. So I think of race as how society sees you and thinks of you. Okay, next. So racism is a system of structuring opportunity and then assigning value based on that race, on how society sees you. It unfairly disadvantages some individuals and communities, and therefore unfairly advantages others. And it also saps the strength of the entire society through the waste of human resources. And there's several levels of racism. Typically, we think of personally mediated, when what someone says and how someone interacts with people, and that's what people think about, and that's what people get upset about if they've been labeled as being racist, because they say, I don't do that. There's internalized racism, where people may take these messages, these negative messages about themselves, and they believe them, and then they have low self-esteem. But then there's structural institutionalized racism, where it's embedded in different systems, and we'll talk a little bit more about that. Next. So while race is how society looks at you and labels you, racism is what the society does to you based on how it sees you. Okay, next. And we saw, so thinking about structural racism, we recently saw that in action through COVID. So this slide has a little cartoon with people at the upper end of the caste system. They're playing the violin, they have lots of space in their apartment, and as you go down, it starts getting more crowded, more activity, until you get all the way down to the bottom. And what we've seen is increased rates of COVID infection, hospitalization, and deaths in a variety of marginalized groups, both by race, ethnicity, but also a variety of other factors, those that are institutionalized in correctional facilities and similar. Next. And so we see this dramatic increase in the likelihood of communities of color to have COVID complications. Next. So how did this disparity come? So really what we saw is people who had increased risk of exposure, service jobs, poor housing, public transportation, high chronic disease burden, diabetes, kidney disease, hypertension, asthma, chronic obstructive pulmonary disease, lack of access to quality care, early testing shortages, poor preventive care, low quality facilities. And those all come together next to increase people's risks. But these don't happen by accident. They're all coordinated through a system that's called structural racism. So we said the resources are allocated in a particular way. Residential segregation is one of the main pathways through which we see allocation of many of these community resources. And Dr. David Williams talks about that a lot. Underfunded school systems, poverty, et cetera. And all of these factors are much more common in communities of color because of how racism is structured in society. Next. And again, it doesn't happen by accident. Dr. Don Berwick, the former director of CMS, is frequently cited with this aphorism. Others have said it. Every system is perfectly designed to achieve the results it gets. So we keep hearing, oh my God, there's something wrong with the system. No, the system is perfect, doing exactly what it's designed to do. And so there's nothing wrong with the system. If we want a different answer, we need a different system. Next. So to just summarize the structural racism, it's this mutual reinforcement of systems, housing, education, employment, et cetera, that lead to these disparities we see. Okay. Now, importantly, no one on this Zoom owned an enslaved person. No one in this Zoom created structural racism. But everyone on this Zoom, regardless of your identity, has the opportunity to do three things. You can continue to actively promote structural racism, policies, practices. You can sit back and say, I really don't want to get involved and do nothing, and it will continue to go on, go forward. Or you can help dismantle it. And if you're helping to dismantle it or work against it, then you're practicing anti-racism, right? So that's very important because a lot of people need to realize that there are options they have, regardless of your identity, regardless of your race or ethnicity. These are the choices you make. And you can be a person of color and make a choice to promote policies and practices that are consistent with structural racism. So that's also important to know. Next. Okay. And again, these patterns that lead to structural changes and impacts strongly influence what happens at an individual level. And I'll talk a little bit about that more later as we start transitioning to community. Next. So I want to do a quick walkthrough. Probably this audience probably knows it, but there may be some people who are not as familiar. When we think about achieving equity and justice to eliminate disparities, we have in this corner many of the social determinants of health, those factors that racism, those structures that racism operates through to embed differences in society at a systemic level. Next. And what we have is an aspiration toward that creed of all men are created equal, all people are created equal, this meritocracy, right? Where everybody can climb this ladder and reach that goal, get that diploma, have the American dream. Next. But that's not what we have, right? So we have some groups that have a whole lot of boxes to step on, and it makes the ladder that they have to climb not as high. And I've outlined many of the elements of those ladders. And some people have fewer boxes, but they have some boxes. I would argue that Black and Indigenous people of color, LGBTQ+, women and others, through laws, practices, policies, ongoing narratives, they not only don't have boxes, their ladder is actually in a hole, right? So they're starting from a hole. Next. But it's not just that they're starting from a hole, their ladder is broken. So they're climbing a ladder, so they have to get into the hole, climb up, and the ladder is broken, right? Because as they're climbing the ladder, they have to go across implicit biases and poor school systems and limited healthcare and all sorts of other things. So that makes it the microaggressions that people have to face. So they're trying to get through, and it's not looking like a meritocracy. Next. So we talk about increasing diversity. And if you look at that broken ladder in the hole, you now see more people around it. So increasing diversity, it's helpful, it's good, we want to do something there. But putting a lot of people to now have to go in this hole and climb out and climb up that same ladder that's broken in the hole is not a good solution to get more people to the top. Next. So diversity alone is not helpful. And so what we really need is equity, right? And so what equity does is it fills in that hole. It gives people a couple boxes and it fixes the ladder. And justice is one of the strategies to help make equity happen. Now, what's important to realize next, and this is where the narrative, oh, go back a second. This is where the narratives come in that we hear. After the inequities have been created, when you then say, let me fill in the hole and let me give a box or let me fix the ladder for these people over here on this side, what you hear is, oh, we're not treating everybody equally anymore. That's reverse racism. And so it's very important to be clear about how words are being used and how narratives are being created. And so there's a sense that once to create the inequities, that's fine. But now, if you just treat everybody equally once they're created, then everything stays the same and there's never a chance to catch up. And so equity has to be giving back and taking care of those holes and giving some boxes and fixing that ladder. And so I just want to make sure people are clear about that, because you hear this reverse racism all the time. And what reverse racism says is, you just said we should treat everybody equally. And no, sometimes it's equally, but sometimes we need equity. And we need equity until we get to equal, and then you can treat everybody equal. Next. So what about race and ethnicity in research, right? Because a lot of us are here doing research. Next. So this is a conceptual model of race in research from Dr. Leveist, right? Former colleague here at Hopkins. And importantly, I don't want to go through the whole model. At the top, we have race, and we go through all these other things till we get to health outcome differences by race. And so what's important is, look how far away race is from the health outcomes. So it's really not race, it's all these other things that happen afterwards that are important to health outcomes. And that's why it's racism that is actually that risk exposure for health outcomes and not race. Race is just who you are, racism is what's done to you. Next. So when we're using or thinking about addressing disparities in research, we want to think about why we're using race and ethnicity, why we're examining it, how we're examining it. We need to recognize that there's a lot of heterogeneity within each racial ethnic group. Everybody's not the same. Everybody's not treated the same. And then we need to understand the impact of structural racism on the research question that we're asking. A lot of times we want to control for socioeconomic status, or say we'll use socioeconomic status as a surrogate for race ethnicity. They are not the same. And not only are they not the same, there are many elements and threads of racism that impact socioeconomic status, right? So not only is a race and ethnicity separate from, but racism is embedded within socioeconomic status. Okay. So again, it's important to understand that race and ethnicity may be associated with certain health outcomes, but they are not the risk factors. They are just associated. The risk factor is actually racism. Next. So again, race is a risk factor for racism. Next. And racism is the risk factor for health outcomes and health disparities. Okay, next. Next. I want to just talk for a minute. We talk about the biology of race and that race is biologic. Race is not biologic, but racism is biologic, right? So we have this concept of weathering, first expressed, commonly attributed to or linked with this paper from Arlene Geronimus back in about 2019, early 1990s, with the weathering phenomena, that Blacks experience early health deterioration as a consequence of the cumulative impact of exposure to social and economic adversity and political marginalization, right? So so basically it's just a whole lot of extra stress, right? And if you have stress, it can shorten your telomeres, it can impact your health. Barack Obama, his hair went pretty gray pretty quickly. Now, it could have just been that was his time and it was going to turn gray anyway. Or it could have been all that extra stress made it happen. But when that extra stress is going on, it affects our entire body. Next. And so we see that there are differences in adversity by racial ethnic groups. So here, from the MIDAS study, midlife study in the United States, major discrimination, everyday discrimination, major life events, and socioeconomic adversity, all greater in Black than white participants in this cohort. Next. And that becomes expressed physiologically here with increased levels of fasting glucose, insulin resistance, inflammatory markers like C-reactive protein, IL-6, and E-selectin, increased waist circumference, increased BMI in comparison to the white participants, despite the fact that the Black participants are 5 years younger, right? So they have more physiologic adversity despite being younger. Next. And what's shown here is the predicted probability of mortality. I'm sorry, predicted probability of having a higher allostatic load as related to poverty income ratio. And what's important is the two top lines, which means there's a higher risk of having allostatic load, are both Black patients or Black study participants. The highest line are Black study participants with more poverty. The line below it is less poverty, but they're both worse than white study participants with high poverty. And then the best line at the bottom is white participants with high poverty, with low levels of poverty, right? So a lot of times we hear, oh, it's not about race, it's just socioeconomics. So A is not just about socioeconomics, and B, socioeconomics is all about race/racism. So those go together. Next. And then finally, as shown here, this is data looking at lifetime discrimination and inflammatory burden, unadjusted to the left with a value of 0.31. And then even if you adjust for socio-demographic factors, health behaviors, and anxiety and depression, you only marginally reduce the inflammatory burden associated with lifetime discrimination, suggesting that there are these other factors that, again, are linked to, quote unquote, they're unmeasured confounders, but probably somewhere in the other levels of structural racism that are causing these differences. Next. So let's get back to race and ethnicity in research. Next. So race is a very complex population level social variable, right? Because we use it in research, but it's very complex. Research data on race ethnicity is critical for population level assessments, right? It's a population level variable. We can use it for population level assessments. And so we can say Communities of color are 2 to 4 times more likely to have COVID and COVID complications. We use that to inform public health messaging, public health and community messaging. We use it for screening. We should be using it, we say we use it, we should be using it for identifying who should be getting vaccinated first, right? So there are important reasons why we want at a population level to continue to use race and ethnicity and understand it. And then we can follow to see, are things getting better, right? So we know diabetes is more common, and high blood pressure and chronic kidney disease and HIV. And so many medical conditions are more common in different communities of color. And so having that information is critical at a population level. Next. And we use this information frequently for health disparities research, where we want to compare information between different groups. We can also then stratify populations if we want to do minority health research to look at health issues just for one particular group. And a lot of times this is challenging for many people in the research community. They submit papers and the reviewers are like, oh, well, there's no control group, basically, which means there's not a white control group. So why are you looking at that? And the reason is, I'm interested in Black men's health. I'm interested in Hispanic women's health. I'm interested in Asian health, et cetera. And so that's really important to look at and understand that is an important avenue of research and a very necessary avenue of research. Next. So some of the other types of research and strategies we think about when we're trying to look at disparities, qualitative research, that gives us really good insights. And a lot of times we like doing, and we have community engaged research, but doing research with communities. As a researcher, important to think about types of research we're doing. When we think about insurance and being insured or uninsured, having insurance does not mean access to care. It means potential access to care. Those are two different things. So a lot of times when we do analyses, we look at insured, uninsured, and we assume everyone who's insured has access to care. They do not. And it's particularly more likely to be associated with still potential and not true access to care in marginalized communities, communities of color. Next. For those researchers doing Medicare analyses, it's also important. There we have, we now have a state where everybody has some level of insurance, regardless of their background. But for many persons from communities of color, they may have had many, many years of not having insurance, not having access to care. And so they may have this high allostatic load, this weathering. And so it's not necessarily a equivalent comparison just because we're using Medicare data. And that's important to understand. Similarly with Medicaid, although it's helpful, Medicaid usually more in children and younger people. So that's helpful at least to know we're looking at groups that are somewhat similar. Depending on questions people want to ask, they may look at closed health systems such as Kaiser or the VA, where there may be some intrinsic biases, but there's generally more equity in care. Open health systems, those with large electronic health record data, and then large observational data sets. So these are all great opportunities for people interested in doing research in disparities, but it's important to be cognizant of what the limitations might be. Next. So we usually say we want to control for these things. So imagine, look at all these things here we want to try to control for, right? And so we look at sort of neighborhood, socioeconomic disadvantage, and it really shouldn't be called, it might better be called socioeconomic inequity, right? Because it's not that a group is disadvantaged, something was done to that group, right? So there, an inequity was made, or it could be socioeconomic oppression, right? Because there was oppression that happened that is why they're in that situation. So here's a whole bunch of things we frequently want to control for when we're doing research. But the important thing is think of all the things that we're not able to control for, right? But also each person, even if you're Black, Hispanic, Native American, each of these affects each individual person differently. So as a group, we may come up with some numbers, but individually, each person's affected differently by these different factors. Next. And so that's important because that comes to how not to use race ethnicity in medicine. Next. And as a physician, I know that well because we do it all the time and we need to stop doing it, right? So for diabetes, we can say the Hispanic community has 1.5 times the rate of diabetes. And we can say they have a higher average hemoglobin A1C. And we want to do education, we want to do outreach, we can do screening. What we should not do is create a formula and subtract 0.5% from the hemoglobin A1C of every Hispanic patient and then give them that number, right? Their hemoglobin A1C is what their hemoglobin A1C is. And even if it's good, we may say, you know, you belong to this group. I want to make sure you come in a little more often or take extra care of yourself because as a member of that community, you're at higher risk, even though your particular blood test looks really good. Next. And so in creating these clinical formulas, algorithms, even risk predictions in medicine, we want to come up with a single number that we can apply equally to every person of that group, right? And that's a problem. And so I have colleagues and I say, oh yeah, I understand completely. Race is a social construct, but it still should be in the formula, right? So the formula treats race as a fixed biologic variable. And if you keep putting it in there, then you're denying it is not a biologic variable. It ignores the large, both genetic and social heterogeneity within groups. And it reinforces racist stereotypes. Racist stereotypes is, here's a group, I've labeled the group as something, and now we'll give that same label equally to every person, regardless of where they stand. Also, it obscures the mechanisms and obscures the investigation into potential ways through which racism may be leading to health disparities. And again, it assumes everyone is exposed equally to the myriad of elements through which racism operates. And it also lacks the understanding that race itself is not a risk factor for racism. I mean, it's not a risk factor for health, it's a risk factor for racism. So it's very imprecise. And so that imprecision is called an ecologic fallacy. We have this, what's called aggregation bias. And this is important. Again, at a public health level, that imprecision is not bad. We know if you belong to that group, that's important. You're 5%, 10% more likely to have early colon cancer. We want to do screening, but we cannot scientifically, with confidence and credibility, say each and every Black person who I see has a 10% higher risk of colon cancer. Next. So what about conducting our research? Next. One important approach we don't see frequently, but we do see it in some papers, and this is some colleagues of mine, where they actually outline in their paper a conceptual model where they look at all the ways in which they are, so here they're looking at residential segregation and health outcomes. And so they've outlined all the ways through which they are hypothesizing and analyzing how how residential segregation, they're hypothesizing, is going to lead to differences in health outcomes. And so they have this nice model and they've outlined it and they've put it there. And that's very helpful, right? Because that's what you want to do when you're thinking about your research, you're putting it together, and when you're publishing it. You want to make it very clear and explicit. Next. So what's the way forward? Next. Or a way forward. I don't know the way forward, but a way forward. So again, do we understand what it means in the study, what race or ethnicity means? Also, are we thinking about its intersection, right, with other factors? Because racism doesn't happen by itself, right? We have sex, linguistic background, sexual orientation, others. For a lot of the work we're doing, do we have the right partners? And who is not at the table? And for me, that means my community partners, right? But there also may be, do we have specialists in critical race theory as part, or sociologists or others who should be part of our team, right? So we want to be thinking about that when we're doing our research. Next. Oh, do I have time for this? I'm not going to go through this, but what I want everybody to do is just for yourself, right? So this is the Adverse Childhood Experience Questionnaire for adults. So just read through these and come up with your own score, right? Did you feel you didn't have enough to eat, had to wear dirty clothes, and had no one to protect or take care of you? Did you lose a parent through divorce, abandonment, death, or other reason? Did you live with anyone who is depressed, mentally ill, or attempted suicide? Did you live with anyone who had a problem with drinking, using drugs, including prescription drugs? Did your parents or adults in your home ever hit, punch, beat, or threaten to harm each other? Did you live with anyone or live with anyone who went to jail or prison? Did a parent or adult in your home ever swear at you, insult you, or put you down? Did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Did you feel no one in your family loved you or thought you were special? And did you experience unwanted sexual contact growing up? So just come up with your number. It's for yourself. Next. And with that number in mind, where do you fall? So 61% of adults had at least one ACE, one. 16% had 4 or more, okay? 16% 4 or more. Females and minorities are more likely to have more than 4. Persons who experience more than 4 are 2.5 times more likely to have obesity, cancer, everything bad, everything bad. So again, it's not what's wrong with you or them, it's what happened to you or them, right? So we're gonna be thinking about that. It was sobering when I did mine. It was like, I was amazed at how high it was. Next. So the way forward, the World Health Organization says improve conditions of daily life, improve equity in the distribution of power, money, and resources, and develop a workforce trained in the social determinants of health and raise public awareness about the social determinants of health. So I'm going to end up a little bit focusing on that. Next. So one of my colleagues, Adam Chickendance, did a questionnaire asking primary care providers, social workers, and nurses how confident they were in their ability to address social needs. So one, should we be screening? So 84% said yes, we should be screening. How confident are you to address something? Less than half. How often is it happening currently? Less than a quarter. And what are the most significant barriers? Lack of time, lack of resources, right? So this is really important because we're trying to address disparities, and these are the factors that contribute to disparities. So we have an understanding of what's needed, but we don't have the time or resources to address disparities. Next. So if we think about all the factors that contribute to health, I put a red box around clinical care, which is 20%. So that's like my box mainly, right? Then I put black boxes around health behaviors, 30%, social and economic factors, 40%, physical environment, 10%. Who knows the most about those? So in the health system, public health people, population health people probably know more about that. But overall, our community partners know more about those three boxes than the people in academia, right? So that's 70, 80% is in their space and 20% is in our space. So if we're doing research and we're not partnering with them, we're not able to do a good job. Next. Or I would say we're not able to reach the heights that we could reach with them. So I talked earlier about structural racism and beliefs and preferences, and we keep hearing, well, people just choose not to be great. They choose to do drugs. They choose not to go to school, et cetera, et cetera. And so we have this narrative of racial difference. And we also have this narrative that these are individual choices independent from racism, right? And they are choices to some extent, but they are still strongly influenced by the weight of life circumstances. So they're not independent per se, right? But we are told that to reinforce that inferior people are making poor choices of free will within this quote unquote meritocracy. And think about it. A non-adherent mother may choose not to refill her meds, but she made that choice because she chose to buy food for her kids, right? So it's a choice she made, but that choice was, again, influenced by the weight of her life circumstances. So beliefs and preferences are, in fact, a large part linked to the social determinants of health and linked to structural racism, and therefore linked to disparities because they can be strongly influenced by unfair or unjust circumstances. Next. So one project we put together in Los Angeles, this was when I was at Charles Drew University, it's called the Community Faculty. We went through a whole process to, we took community partners that we had been working with for a long time in different research projects, and we were able to take a adjunct professorial track per se. We called it community faculty. We worked with the dean's office, we worked with the dean, we worked with the president, because I was the interim president at the time, so I could make it happen. And my community partner, Loretta Jones, who's in red here, who passed unfortunately 2 years ago. This started because she said to me, she said, Keith, why don't we have community faculty? And Loretta and I have been working together for nearly 30 years. And so our partnership went like this. Loretta would come up with great ideas and I would try to make it happen, right? That makes me look really good, but she was really the driving force for this. So this was to take a group of individuals who worked with community-based organizations. They understand the social determinants of health. I can get someone to give a lecture on domestic violence, but I cannot get someone who can give our students and our faculty an understanding of domestic violence like the director of a domestic violence center, right? That just can't happen unless at that level, unless I have that person there. And so that's something that we created, and it still goes on today. And many of these people teach. So over the last 10, 15 years, they teach in many programs at UCLA, the Robert Wood Johnson Clinical Scholars, the School of Public Health, all of our disparity centers. And so they either co-teach or teach lectures, and it's something that we're really excited about. Next. And the goal, we think about how to prepare. If we're going to have people be prepared to address social determinants of health, then they have to really understand social determinants of health through a community lens. And so having a cohort of faculty who can teach alongside traditional faculty can really bring that level of understanding around education, violence, social justice, environment, housing, safety, right? And it also prepares both students and faculty to conduct research with the community in a way that they would not usually do. And it helps to force the skills necessary to translate knowledge into community settings. So this is one of the more exciting things that I've had opportunity to participate in. Next. So I'll wind down now. Sorry. So now I'm thinking, so think of your patient, think of what happens to patients in the healthcare setting. So we have structural racism. It increases the likelihood of poverty. There's always discrimination going on. So individuals have this psychosocial stress from discrimination, from the weight of the inequitable distribution of resources. And this stress influences what's called the global workspace in our brain. And it limits our ability to think normally. It limits our ability to make decisions normally. It limits our ability to take actions normally, right? So when you're stressed out, people are stressed out and you're like, why didn't you do that? It seems so simple. Yeah, you're just like paralyzed almost, right? Next. And so we don't think about that as much in healthcare. But when our patients come in and now they're finished their visit and they're ready to go home, we have to understand they're juggling all these balls, right? And they're going home, they're thinking about the cost of food, small margin for unseen events, fear and anxiety, apprehension, being in the healthcare setting, maybe in the home. They have mistrust and stress from social injustices. And that all this leads to an inability for them to remember what we as clinicians have told them to do. It impacts their ability to implement what recommendations we've made to do. And so they're likely to have suboptimal clinical outcomes. But it's not because of who they are, it's because of what we've done to them as a society. Next. And so we need to be thinking about that as physicians, as providers. And if we think about that as not what choices of people are making, but situations people are put into, that society has put them into, and that we're part of this society, then we can think about how can we help enhance that interaction. And then also how might we also, right? And so how do we address our own unconscious or implicit biases? One, we need to recognize it could be us. Two, we want to focus on treating our patients as well as our staff and peers as individuals, not that category we have, right? Because that's being anti-racist, is treating people as individuals, not a category and a label from the category. And then we want practice empathy, caring, and respect. And then for those of us in the healthcare system, we need to work on unraveling the institutionalization of racism within our system of healthcare, of academia. So we have policies, we have practices, we have ways of doing things, cultures, et cetera. And we need to make sure that those are equitable and that those are designed to position our patients to have the best health possible. And importantly, we have to recognize and make sure our peers recognize being passive is a choice and it's choosing to perpetuate structural racism and health disparities. Next. So in caring for our patients, what do many marginalized patients have? They have the fact that they've been labeled and put into this discriminated group. They're more likely to have limited income, be underinsured, have limited educational attainment, limited access to care. They have this impaired cognitive processing because of extra stresses they have, the adverse biologic profile from the stresses over life that lead to more diabetes, high blood pressure, et cetera. What they need is high quality care, treated with respect. They need our empathy, our compassion, our support. They need to be given hope. right? So we heard from Dr. Martin Luther King earlier, Martin Luther King Jr., Dr. Gaskins, about hope, right? So they need to be given hope. What they don't need is our judgment, our ire, and another lecture, right? And so if we remember, it's what's wrong with individuals, if we remember, it's not what's wrong with individuals, it's what did we do to them? That helps frame how we approach things. And then as physicians, we should tell patients that we want to treat them like our family and then treat them and then do that. And I'm assuming we're all going to treat our family well. So tell them you're going to treat them like your family and then do that. So next. So I'll end here and then open up for Q&A. We saw a picture of Whitney Young, and this is a Whitney Young quote that was adapted from Ernest Hemingway. The truth is, there's nothing noble in being superior to somebody else. The only real nobility is in being superior to your former self. So I wish everyone on this Zoom many days ahead of being superior to your former self, and look forward to the Q&A and the rest of the sessions. And thanks again, Dr. Gaskins and the leadership for allowing me to spend some time with the team here today.
Thank you, Dr. Norris. I really do appreciate your presentation, very enlightening. And I've really taken away quite a few nuggets that I'm going to try to implement. Why don't we take one or two questions? We're into our break, but we just got started a few minutes late. So why don't we just take one or two questions? If you have a question, if you would raise your hand or indicate in the chat, and I'm going to take the first.
And I'll be around. I'll hang around. I'll be around. So
then I see. Go ahead, Stephen Rasgal.
Let me unmute. Thank you, Dr. Norris. Long-time listener, big-time fan. Thank you for such a wonderful presentation. And you talked a lot today about the contemporary and the narrative and what we see. In my work, I spend a lot of time on looking at the historical context of why we see what we see.
Right.
And how medicine had their thumbprint, particularly in the 19th and early 20th century, in inculcating that narrative.
Right.
I need you to talk about for a little while how important it is, because I do this work. I mean, lots of physicians are stunned when they when I pull out that 1902 JAMA article, that talks about syphilis and the Black man, right?
Right.
Talk about like how we move beyond like our current space in education, and to a better place of understanding like how we tend to, through our educational formation, further inculcate these narratives.
Right. No, that's a great point. And so as you mentioned, medicine and science, it was the job of the role of those two disciplines per se to establish and reinforce a biologic essentialism of race, right? And then to try to always make sure highlight something inferior, right? And so that's the role of medicine throughout the history. So after it's sort of established, the role of medicine is to reinforce at every step that this is actual science. And it's still in there, as you said, it's still in a lot of it. So we just hired 2 positions for our medical education curricula of structural racism specialists per se, and their job is to go through the curricula and look at where structural racism may be embedded in there, and then and in listening to the lectures, because a lot of times things will come up and people will unknowingly say and make claims and statements that may not seem like overtly racist, but it's actually reinforcing these racist stereotypes and et cetera, et cetera. And so we have to, so in the health professions, we have to go through and revamp, right, all of our educational structure. Because if we don't do that, we have conversations, but the fallacy and the narratives of racism continue to get reinforced through these different tools of learning, right? And everybody just keeps going, reifying it over and over and over again. So what we have to do is slowly go through and take it out. And it's tough. I work with a bunch of people, and it's really hard. And people also need to understand, just because someone is from an oppressed group doesn't mean they're necessarily free from that conditioning, right? No matter of fact, and once the way white supremacy works, once it's sort of seen, it may, sometimes it's conscious, sometimes it's unconscious. Once you see someone from an underrepresented group, or you see a woman who's willing to talk about meritocracy and stuff, they're highlighted. And like, yeah, look at that. They're saying it's true, right?
Right.
And so we have to be very diligent about that as well. But it's a great point.
Thank you so much for that answer. And someone said that it's in social work. I lecture on this stuff. It's in every facet of medicine and everything that we do.
Yeah, it's everywhere. Yeah.
Thank you. I appreciate your answer.
Okay, so I have two more questions. I'm gonna ask Rena and Stephen Thomas to ask their questions, and then Keith, if you could wrap it up, and in your wrap up, just comment on kidney disease and the intersection of racism. So Rena first, and then Stephen, and then Keith, and then we'll go to our break.
Thank you so much, Dr. Norris, for this wonderful presentation. I'm Serena Baba. I'm a FNP DNP student at the Johns Hopkins School of Nursing. And I'm in a class where I'm being trained with others on ultimately providing, diagnosis, treatment to patients. But as I read textbooks, I'm taking a pathophysiology class right now, and I'm looking at signs and symptoms of diseases. We're doing pulmonology, and we're talking about a pink puffer, blue blower. And if you're dealing with somebody who has a dark skin, how do you see that? But what I'm getting to, Doc, is just the fact that I believe the training starts even now in whether it's medical students or nurse practitioners or PA, in changing that whole mentality. What do you propose? I understand, about the community lecturers, but what else do you propose can be done now in medical training to help with the new cohort of providers change that whole mentality, knowing that, race is not a risk factor for health, but it's racism?
Yeah, it's a great question. And we just have to be more diligent at addressing curricula, at making sure the faculty who are doing the teaching are using sort of a race conscious approach, right? And thinking about it and doing it in an understanding way, and not in a sort of what's called a race blind approach. And sometimes, and that's why it's good to have people around who can check you. That's why having community partners around is good, right? Because we're and particularly community partners who are empowered. That's why I like the community faculty or something, because now they're empowered to be in those settings. And when people, they're watching students train and things are going on, like, hold it. That's crazy. Don't say that. Don't do it like that. So we just have to get it in the curriculum. We have to get it both in the written curriculum, but we also need to have training for or remove people who are doing some of the teaching now, particularly for the next generation, to have people who are more competent and sensitive around these issues. Thank you for the question. Steve,
Thank you.
Yeah, this just very briefly. First of all, it's really good to see you, Dr. Norris. I would never have imagined that it would be California where there was a demonstration by anti-vaxxers to shut down a vaccine site. Okay, of all places, California. So that's context. And now I'm hearing terms like woke and cancel culture being used like a slur.
Right.
Okay, so if we're the choir, most good choirs practice, how do we practice responding to this kind of pushback? And then the algorithms of oppression, as increasingly more and more things go online and get digital, and you don't have an individual to point to, it's
Right.
all in the computer now. I'll just use one example if you could speak to, and that's the oximeter. We all now have thermometers in our house, and now some of us have oximeters in our house. And guess what? Those oximeters are not accurate on dark skin. How do we go through not only the curriculum, but these clinical measures that have embedded in them bias towards people of color? Thank you very much.
Thanks, Dr. Thomas. So yeah, a friend of mine would always talk to me about California, and I remind him, California is the home of Nixon and Reagan. So don't be fooled by what's going on necessarily in California. But it's a great question. When we hear these narratives about woke and the pushback on the other side, what those narratives move people, they want to have a conversation about two sides having, in a sense, what I would call saying they're different approaches, but in fact, the values are completely different, right? And so I think it's important to step back and say, what are the values? One side wants the right to be able to continue to oppress the other side. The other side wants freedom from oppression. And just like, during the 1950s and 60s, Malcolm X was, and to a certain extent, Baldwin were very, open to quickly call out these other narratives of why are Black people so hostile, right? You're being beaten with a stick and you reflexively grab it, or you're hostile, right? So when values are similar, then I'd say, then you can come back and have a conversation. And if in fact we go back to America's creed and we're going, if we say we're trying to hold the values of the nation and therefore we're trying to move toward equity, then I think that helps to put at least a different spin on these narratives and trying to bring, to try to say both sides, there's good people on both sides. There can be good people on both sides, I'm sure, some of the worst people, their family members like them in this and this and this. But in this issue, they're trying to promote a narrative and a policy of oppression over another group. Those are just not equal. And then they're just so dissimilar. Don't even get in those conversations, because the conversation then says we are somehow labeling these as equal and worthy of having a conversation about. So I see the thing for time. There was one other thing that was supposed to be.
Yeah, the oximeter, the algorithms of oppression.
Every clinical tool, in my mind, that has a specific outcome for an individual by race, ethnicity, as a, for that then claims it can precisely give information for every person of that group, needs to go away. Because it should only be done at a public health level. It cannot be taken down. It is reifying this stereotype that race is biologic, and that we can take it down and that we can use it the same way we might be able to use someone's blood pressure value, and it's not. And so we just have to take it out. And I know medicine is fighting tooth and nail to keep it in, because it just can't get rid of race. Remember, we have EGFR. They say, okay, we can take it out, but let's keep the same formula, but let's just take the name race out.
For those who don't know what that is,
that's a formula for measuring kidney function. And so there's a for the formula for measuring kidney function, you get a different number if you're Black, right? Now you don't get a different number if you're Black in Brazil. So they've done it in Brazil, and they've looked at Black, mixed, and white, and it's the same. They've looked at South Africa, and they've looked at Black, white, and mixed, it's the same. So if we got on a plane with our blood tests, we would have a certain measure of kidney function here, and when we landed in Brazil or South Africa, we'd have a different number.
Wow.
And people are going to tell us that's pure science.
So
I'm gonna.
okay.
Thank
Thank you so much.
This is a fascinating conversation, and Dr. Norris, I want to really thank you for just a really stimulating and enlightening presentation. I could sit and listen to the conversation questions all day long. However, we do have a community panel that I know you wanted to participate in. And then I have some poets coming on who are going to really share with us some insight. So I want to make sure that we get to them. So we're going to first, before we hear from the community panel, we're going to hear from Dr. Warren, who's going to lead our next presentation.
Thank you so much, Dr. Gaskin, and thank you to the entire planning committee for hosting this event. Chantel, if you can spotlight Dr. Denise Folks right now, please. There we go. And I just want to ask everyone, if you have an opportunity to please turn on your cameras if you can. Our youth poets have done an amazing job preparing for this, and we want to show them our support on today. A quick introduction. Dr. Gaskin, I think that you laid the groundwork for the conversation today about race and racism. Your story about Mahalia Jackson's contributions to nudge Dr. King to give his "I Have a Dream" speech was just simply amazing, right? But right here in Baltimore, Maryland, we have our very own Mahalia Jackson, who actually reigns from West Baltimore 21223, and that is Dr. Denise Folks. Dr. Denise Folks has an extensive bio, but I want to be sure to just highlight some of her key accomplishments. One, she is a proud graduate of Walbrook Senior High School. She earned her Bachelor's of Science degree in Adapted Physical Education in 1984 and a Master of Education in Vocational Rehabilitation Counseling in 1988 from Coppin State University. Dr. Folks has also earned many seminary degrees, namely a PhD in Pastoral Clinical Counseling from Sarasota University, and as well as a doctorate of ministry from Family Bible Institute College and Seminary. She is a professional clinical member and a licensed clinical pastoral counselor, advanced board certified with the National Association of Christian Counselors, and she has completed additional graduate studies. Dr. Folks, of course, we know that she is the CEO and foundress of Positive Youth Expressions, that reigns from West Baltimore, Maryland. Dr. Folks is also a writer and an author, and she released her very first book of poetry entitled From Darkness to Light, A Living Testimony of Poetry in 1997. Since that, it really laid the impetus for many publications and poetries and books. And she even publishes a community monthly newsletter focusing on health in body, soul, and spirit called The Metamorphosis. She proclaims that good health is freedom in body, soul, and spirit. We welcome Dr. Denise Folks once again, who is also the CEO of the Greater Youth Christian Academy and Little Folks Child Care and Early Learning Technology. Our Positive Youth Expressions poetry team is sitting right there to the left with the lovely pink face mask is Nancy. Nancy is a fourth grader. Wave at us, Nancy. And then in the middle, we have Blake, who's a fifth grader. Can wave at us, Blake. And then we have Shania, who's to the right, and she's also a fourth grader. And behind the scenes, of course, they have a wonderful instructor who have helped them to put together their poems for today. And as Miss Denisha Johnson. So we thank you, and we're honored for Positive Youth Expressions. And take it away. They're giving us 2 poems, guys. They're entitled Generations Poem. And then the second poem that they're going to deliver today is If I Was Dr. Martin Luther King, If I Was Dr. MLK, which is so befitting for how we started this conversation. Thank you, Dr. Folks, and thank you, Positive Youth Expressions poetry team.
Generations. I want to know you, Grandma and Grandpa, too. Tell me all your stories. I want to live as long as you. What mountains did you have to climb? What giants did you fight? Do you have any war stories? Did you sleep in caves at night? Were you a slave from Africa? Did you set the captives free? Did you march with great leaders? Did you sail the untamed sea? How did you get to be so old? Where do your secrets lie? Will I someday look like you when my childhood days fly by? I want to know you, Grandma and Grandpa, too. Tell me all your stories. I want to live as long as you. If I was Dr. MLK, if I was Dr. MLK, I'll fight for freedom every day. I'll tell my teachers, parents, and every friend about the peace to fight for until the end. If I was Dr. MLK, I'll be sad all about the drugs today. I'll tell my people to just say no. It's poison lead you down that road. If I was Dr. MLK, I'd destroy all the guns that kill us every day. I'll cry out in a loud, loud voice. Peace and love is God's only choice. If I was Dr. MLK, I am Dr. MLK. His dream lives deep within to help me strive for freedom from the sin of men. I am the dream of Dr. King. I'll fight for freedom until I win.
Thank you so much. Thank you so much. Please, please join me in applauding Dr. Denise Folks and our Positive Youth Expression Poet team. Stand up, guys. Stand up. Please spotlight them. Please spotlight our scholars.
Fantastic.
Excellent job.
Yeah.
Yes, great job. Great job.
Great job. Dr. Folks, quickly, I'm going to give you an opportunity to I think we have 10 minutes or so, well, for our segment, but I want to give you an opportunity to just share some words with, we have over 100, and at one point was 150 participants joining us on today. As you know, Dr. Keith Norris is as well here, joining us from UCLA, and he gave us our keynote remarks. And Dr. Gaskin, of course, is our leader over the Center of Health Disparities, the Center of Health Disparities Solution at Johns Hopkins Bloomberg School of Public Health. So one, I am so honored. The chat is really blowing up right now. Everyone's saying excellent job. Thank you, thank you, thank you so much. Wonderful job. Thank you so much. You, Nancy, Blake, and Shania should pat yourself on the back. Yes. We are so proud, and I'm just so honored. When I arrived in Baltimore in 2015, Dr. Folks was one of those community leaders and advocates who took me in and took me under her wing. And so one thing that they gave me as a gift when I arrived, first of all, they put me on the spot. I thought I was just going by to give a little visit and give a little greetings from Bon Secours. And I remember that it was Black History Month in February. I went to pay a visit. And two things Dr. Folks did. She gifted me a little piece of kente cloth, which I wear on today. And then she also put me on the spot to share my testimony and my culture with them, which I wasn't even prepared to do. But that's the nudge, the Mahalia Jackson nudge that Dr. Folks brings not only to current leaders, but also to the future leaders that we see. So Dr. Folks, please share with us. Tell us about positive youth expression. Tell us about how you've been handling things, during COVID times. You've been successful also to develop another center, right? The Hope Center. Just share a few words with us, please, Dr. Folks. Thank you.
Well, first of all, I want to thank you all for inviting us to the Johns Hopkins University Health and Disparities Symposium. Our children present, promote, and proclaim poetry all the time. Positive messages, powerful messages through poetry. Our mission for positive youth expressions is to encourage and empower children, youth, and families to seek excellence in body, soul, and spirit by providing formal and informal educational experiences. We are now celebrating 27 years of service to children, youth, and families in West Baltimore and Southwest Baltimore City. We started in 1993. We are a nonprofit 501c3 organization. And the children today, they presented those two poems, Generations, because we are celebrating Volunteer History Month or Volunteerism Month, and that is this month. And we do have foster grandparents in our program, so they recited that poem to honor them. This is also the 25th year of National Poetry Month, so it was befitting that they do poetry for our singers, and not just our singers here, but our singers nationally, those who are still volunteering. So we thank God for them. Yes, we have built a new center in West Baltimore, Positive Youth Expression Center. We've been in this building since 1999. It is for children 0 all the way up to age 13. We've had children come in the infant room and stay through the whole program and graduate in the 8th grade and go to choice schools. So we are excited about what we're doing in positive youth expression. And we just don't do childcare. We do affordable housing. We have a whole new area called New City of Hope, where we raise houses and build literacy hubs for children, the new childcare center and youth center. And now we're about to raise some properties to build a senior center to bring in intergenerational programs for our young people. So Dr. Tatiana, thank you so much. And John Hopkins, thank you so much for inviting us to present, promote, and proclaim.
Oh, thank you so much, Dr. Folks. I know Dr. Johnson is behind the scenes somewhere, but I know that the chat is really jumping. I see about 40 messages. So if we can get in contact with you, I know Dr. Johnson just put that website in the chat for us. So please do not hesitate to reach out to Dr. Folks. We know that is a team effort. You just said that you have, adoptive or foster grandparents to help with your youth. So I'm excited about that. I know when I was in Baltimore, I volunteered and spent a lot of quality time with you guys, and it's just always a wonderful and refreshing time. So please, those who are tuned in today, do not hesitate to reach out. They are a 501c3. So if you do have a dime, be sure to drop that. But if you don't have dimes, be sure to spend some time, okay? Dr. Folks, thank you so much. Dr. Gaskin, I'm turning it over to you.
Thank you so much. All right, thank you. All right.
Thank you, Dr. Warren, for those young people were just very exciting, and I'm just overwhelmed by their presentations. And I think Jimmy Slade says it best. Yes, we appreciate your appreciation and your accolades, but if you can send some dollars too. And I'm sure that Dr. Johnson and Dr. Folks will appreciate it.